All right, in this video today, we're going to talk about 3 ways your doctor actually makes knee pain worse. Yes, I'm a doctor. I'm going to talk about what I do, but I'm going to talk about also what is conventional in orthopedic practice and why I think some of those things are a really bad idea. So number 1, NSAID medications. Number 2, cortisone injections. And number 3, wait until you're miserable. The infamous line that's given to a lot of people that may be confronting surgery and they're told something like, hey, when this gets bad enough, come back. Hey, when you're miserable, come back. But let's dig into why, because that's very simple to say those 3, but why are they a potential problem from my perspective as a regenerative orthopedic doctor? So when in pain, what have we been trained to do? This is a funny slide from an actual pharmacy in town. And the sign was burned out, of course, and it says pharmacy. So instead of helping us, sometimes these medications can hinder us and they can impair necessary functions in our bodies. So if we talk about NSAID medications, non-steroidal anti-inflammatories, they're designed to squash inflammation. On the surface, that's a really good idea. You hurt, you don't want to hurt, you take medication, it shuts off inflammation, fantastic. Or is it? Because there's mechanisms now inside of the body, chemical reactions that count on certain enzymes to run those chemical pathways. And we take those medications, we disrupt those pathways. So this is why we end up with side effects, right? So we take a lot of pain pills in the US. We take a lot of these non-steroidal anti-inflammatories. I think at one point I read an article saying it's 80 billion doses, which is hard to fathom, but that's what people consume collectively in the US of things like ibuprofen, naproxen, other prescriptions like Voltaren, Celebrex. And again, these are all doled out, and I was trained to do this in my practice. Hey, you hurt, here's the medication. So how do NSAIDs work? In this slide over here, what it talks about is a primary mechanism. And again, what we're doing is we're blocking an enzymatic pathway with these so that we shut off the cytokines and prostaglandins and leukotrienes and all these fun chemicals that cause the tissue to be irritated and your brain to register that as pain, okay? There's a purpose to this. There's a purpose to pain. And the purpose is to tell you to give your body some time and space to heal. Now, what we've been programmed to do is block it by taking those medications. But if we're always blocking it, I'm gonna kind of smooth out a wrinkle here for you. When we think about this in regenerative orthopedics, inflammation is actually necessary. And I'm gonna say that again. Inflammation is necessary for the body to heal. So if the first thing we do when we hurt is reach for that bottle of ibuprofen or naproxen, Voltaren, whatever you have at home, and you start downing those, as I was trained to do in my sports medicine training, as soon as somebody's hurt, man, we want to get the ice on them, we want to get those anti-inflammatories going. Well, now that things have kind of pivoted a little bit to understanding these mechanisms that we do in regenerative medicine, we actually want a little bit of that inflammation. If your knee is actually swelling up, we don't want you to be swollen, but it has a purpose behind it, and that purpose is to actually shut you down so that your body has the time and space to heal. Of course, I don't want any of my patients to hurt, so we start to think about what can we do to pivot and modulate inflammation there instead of blocking it. So there's a difference there. So we can use natural things. We can use curcumin or turmeric root. We can use arnica, boswellia, CBD compounds, we can use fish oil or fish oil metabolites. So we have a host of natural things that don't have these appearing effects on those enzymatic pathways where one could have stomach upset, they could have ulcers, you could have heart issues. You know, there's black box warnings on all those medications about cardiovascular effects of these medications. So if we have other options over here where we can take care of the pain and the inflammation, we can get around needing to use these. And it's a much better way to treat pain in my perspective, and that's what I do with my clients. Now, if you continue to have pain despite, well, the conventional route of taking the NSAIDs or the other route over here of taking some natural things, what are people offered next then to treat the pain? In conventional orthopedics, where they land next is, hey, you got a really bum knee? How about a cortisone shot? Seems like a good idea. We've been doing this stuff since the 1960s or 70s. We're able to inject something directly into, say, a knee. So to me, better in a way. If we're taking those other medications, it could have all those systemic side effects. But now if I'm putting steroid directly into that joint, I don't have to have that collateral damage on the rest of your body. Which again, checks the box for me. More direct, more precise, at the target, makes sense, or does it? Because when we take steroid, as this article shows here, if we take steroid and we put it into a joint, this was published in 2015 at Stanford, and they looked at the effect that cortisone has, so corticosteroids, commonly referred to as cortisone. We take steroid and we drop it in the joint. What happens? And at what concentration is the important caveat to this. That's what I teach all my patients. Because what they found in this study is the beneficial doses are quite small. So if we want to shut off this loop of inflammation, which we want to, so you don't hurt, the knee doesn't swell, body can get on its way to repair, the dose needed to do that is quite small. A few milligrams is what they studied. Has the effect that we need. Okay, what happens when we crank up the dose? So instead of a few milligrams, what if we went to 40 milligrams or 80 milligrams? Because that is the conventional dose that most patients are given when they have a shot. What do you think happens? Well, in the study, what they showed happen is it became toxic. What does that mean? It means it literally started to kill cartilage cells. So if we're injecting this into one's knee, and everything in my practice I'm trying to do is extend the longevity of one's joints, would we want to put something in there that actually destroys the very thing we want to protect and preserve to have that longevity? The answer is no. And so this is an example of what has been known for almost a decade now, but continues to be done for people. And again, it's not ill-intentioned. I don't think docs are malicious. I think we're just misinformed about how much we need to get the effect, and we don't have enough education to know what the other options are, right? So steroid injections equal, at dose, a toxic effect for your cartilage. So it's bad news. And when we see that done repetitively, where do you think it goes? It goes down the hill faster. So if you're somebody who's middle-aged, maybe you have mild arthritis, and we keep stuffing steroid into your joint over and over to give you pain relief, and a doc may be telling you something like, hey, it's not that bad for you if we stretch it out and only do this every few months, I'm going to disagree a bit with that, because there are other better things we can put in the knee that don't have that collateral damage. Or now that you're informed, maybe ask for a much smaller dose if that's some treatment that you're getting right now, and say, hey, what if we just put a tiny dose in there? Not a big toxic dose. Maybe the better strategy if you're going to continue to use steroids. So this next slide, what it shows is, we get more science, right? We feed that back around in the loop of guiding what we do from a practice and treatment standpoint. At least we should. This is called evidence-informed, evidence-based practice, right? This is what we aim for in medicine. This is the standard that if we're doing research, we're collecting data, we're seeing a lot of patients, treating a lot of patients, we're starting to understand these mechanisms, we should feed this background and change how we practice. At least I do. In this article, they showed maybe these steroid shots aren't as safe as we once thought they were. And this is 2019, so this is 4 years ago. And what this shows is a hip that was injected once, and then we saw a collapse of the cartilage from that toxic effect. Bad news for that patient, because that will go directionally, most likely, towards joint replacement in time. So I think we have to be more careful about these injections. I think they have this illusion of safety, the side effect trade-off profile we always go through. Hey, what's the risk of doing this? Well, now you know some of the risks that you may not be taught, and you can calibrate whether or not this makes sense for you to do that treatment. So if we move on from cortisone shots, what is offered next to, say, old people with bum knees that do meds, then they do shots, and maybe the shots only work for so long? Well, where we get to next is joint replacement, shown on this slide. And this is transformational for patients. We started doing joint replacement in the US back in the 1960s, 70s. And of course, this has evolved like any other technology. If we've been doing this stuff for decades, treatments have gotten better, technology's gotten better. The precision now at which we can put these components into somebody, and I'm a non-surgeon, so I'm a non-surgical orthopedic doc, but my orthopedic surgery colleagues that are doing these, man, what they were doing 10, 20 years ago is nothing like what they're doing today. Sure, the fundamentals of replacing the end of one's joints stay the same, but the components, the materials have changed. How they precisely put these into the patient, you're using robotic assist and a lot of other technology, and it's remarkable that from the time you're put asleep in the OR, you could have your knee replaced in about an hour. I mean, that's just remarkable, but we have the ability, when somebody gets to that point and needs it, that we can change that situation for them that dramatically. From a knee that doesn't function and participate in life to one that now does. So again, remarkable. The question is, do you really need it? And for a lot of my patients, they're in the middle space where they don't yet need that treatment. But they're given the NSAIDs, okay? They're given the steroid shots, and then they're given that third component that I talked about today, which is this line of saying, hey, you know what? When you're miserable enough, come back and we'll do this, right? We'll replace the knee. But some people sit and smolder in that state for a decade. I see patients that are 2 decades in that state, and I wonder what could their life have been had they had some other treatment offered to them 10 or 20 years ago. Because the treatments I do in my practice, things like regenerative, what we call orthobiologics, platelet and stem cell treatments, have been around since the 1990s. And they've evolved through the 2000s to current day to be just like surgery, better. Technology's improved, understanding's improved. And now we have much more precision in doing these treatments to help people that are stuck in that kind of messy, muddied middle space of, I don't know what to do, I don't have any other options, the conventional things don't work, but I'm not ready for this. Or the surgeon even tells you, the patient, you're not ready for it either. So what do you do? Hopefully you're learning some things today about what you can do. You can seek out a different opinion. Somebody that has expertise, specialized knowledge in this area, we call regenerative orthobiologics or regenerative orthopedics, and see if these treatments make sense for you. Because look, the numbers of people getting joint replacement will continue to grow. And to me, there's nothing wrong with that. If we can save knees for people that really need it and give them a better quality of life, that's what we want to do. And our system is built to do that. We have the technology to do that. The new treatments that I'm talking about, things for middle-aged people that have these bum knees, that don't want the surgical intervention, or they're not yet qualified to get that surgical intervention, well, this is where this space is really taken off and can really help a lot of patients, as I've done in my practice for the past decade, treating thousands of patients. So again, if we look at this closing slide, we can take a knee that's beat up, say arthritis. We see the damage on screen here. We see in this slide, hey, there's defects in the cartilage. The cartilage is starting to break down. The ligaments or the tendons are starting to break down. We're never going to be able to take that knee and turn it back to a completely normal knee. Look, patients come into my practice and we treat them, and the first thing they want to do is get an x-ray, get a new MRI to show just like we've turned the clock back 2-3 decades. It'd be cool if we could see that, and we can see changes, and there's published literature to show that there are changes with these treatments, but we don't need to see it. What we need to see in the patient is that they get better, right? That their pain goes way down, that it works better than those conventional things they were doing while biding their time, maybe waiting for surgery, and they can get back out to the activities that they want to do in life. So today, to recap, what we learned is there's some very conventional things that are very effective, right? NSAIDs work, cortisone injections work, surgery works really well. Question is, do you need it? Question is, do you want that? Okay, we've also learned that a lot of people get stuck in this middle space where they think they don't really have any other options for treatment while they wait out their days for surgery. Hopefully you learned a little bit in this video today that there are some other treatments. If you have a knee that looks like this and is telling you it's time for treatment, then it's time for treatment. It's time to find somebody that can give you a different perspective. If you're looking for non-surgical treatments, you should probably see a doc like me that focuses on non-surgical treatments, because I'm going to give you the full breadth and scope of what you can do. And it's up to you, the patient, then, to decide, does this make sense and do you want to do it? So hopefully you learned something today in this video. If you did, click the like. If you like content like this, subscribe, because I'll be doing a lot more education on these kind of topics around regenerative orthobiologics. If you got something that you want to comment back, drop a comment there, and me or my team will try to answer as many of those as we can. And closing in the notes down there, if this is something that resonates with you and you're ready to move forward and see, are you a good candidate for these things, then click the link. It will take you over to a form where you can talk with somebody in my office who can spend a little bit of time unpacking your case and seeing if we can help you in any way. We'll see you next time.